Hello and welcome to the third and final episode of EULAR News here at the Virtual Congress for EULAR 2020. We hope you've really enjoyed the Congress so far and particularly enjoyed today's sessions. I'd first of all like to introduce you to the four reporters I have with me today. So first of all, my name is Rheumatology Day. I'm an academic clinical fellow and junior doctor in rheumatology working in Liverpool in the UK. So first of all, I'd like to introduce you to Eduardo.
Hi, I'm Edoardo Prediletto. I'm a basic scientist and I'm a versus arthritis PhD student. I work in the experimental medicine and rheumatology department at the William Harvey Research Institute in London, and I'm part of the Argos group where we investigate autoimmune diseases. And I want you to introduce to my colleague, Sebastian.
Hi, I'm Sebastián Rodríguez García. I'm a consultant rheumatologist currently working at La Princesa University Hospital in Madrid. And my work focused on research on prediction of outcomes of rheumatoid arthritis using machine learning techniques. And now I would like to introduce you to my colleague, Fabian Proft.
Thank you, Sebastian. Good day, everyone. This is Fabian Proft speaking, and I'm working at the Charité University Hospital in Berlin. And I will present you today my highlights from the poster tours on axial spondyloarthritis and psoriatic arthritis. And now I want to welcome and hand over to my colleague, Mikhail.
Yeah, thank you, Fabian. I'm Mikhail Protopopov from Charité Medical University, Berlin, Germany, and my scientific interests are spondyloarthritis and psoriatic arthritis. So handing it back to you, Mini.
Thank you, Mikhail. So yes, this is unfortunately our last episode of EULAR News for this year, but we have a lot of content to cover. We're going to be covering everything from osteoporosis to spondyloarthropathies. But first of all, I'd like to take you to Eduardo, who's going to tell us about the translational science sessions from today.
Thank you, Miraini. So today has been quite a thrilling day. We had a plethora of translational medicine and data evaluation session. And I think it is worth to mention a few, like the new art of phenotyping and treating Sjogren's syndrome based on the invasive assessment and analysis of possible therapeutic approaches. And also the EULAR origin of autoantibodies to understand B-cell mediated autoimmune diseases, with presentation from Professor René Toos from Netherlands or Professor Michael Carroll from the US. But there is one in particular I really enjoy because it is actually my cup of tea, which is the newly identified cell subset driving disease pathogenesis. So we had Professor Andreas Radbruch from Germany talking about pathogenic plasma cells in rheumatic disease, and Prof. Chris Buckley from the UK discussing the hot topic of distinct fibroblast subset in arthritis, which I'm particularly fond of. A particular talk that I want to report on has been given by Professor Deepak Rao from the Brigham and Women Hospitals of the Harvard Medical School in the US. And the speech was about peripheral T helper cells driving local B-cell responses in rheumatoid arthritis. So in a nutshell, Rao and his group have been quite prolific in terms of publication regarding this topic, describing in 2017 a subset of T cells IgG PD-1 and negative in CXCR5, which are quite abundant in the array synovium. And also, their presence can lead to the inflammatory process through the production of IL-21 and CXCR13. Also, these cells are exquisitely expanded in seropositive array, and their expansion is a major feature of the entire T cells infiltrating the array synovium. So I think it is very important to mention that after being described, these cells have been found to be expanded in circulation in multiple antibody-associated autoimmune disease conditions, such as Sjogren, SLA, and also in diabetes.
Very interesting, Eduardo. And have they described or found out any particular mechanism regarding those TPH cells?
Oh, indeed. They have tried to understand some of the mechanisms that drives these specific cells. And what they find out is that a loss of a specific gene, which is called MAF, and is very expressed in this subset, can actually inhibit TPH cells' helper function. So for last, they moved their attention on a specific type of arthritis, the checkpoint inhibitor-related arthritis, which unfortunately is a side effect of cancer treatment. And what they found is that a fewer TPH cells, but a unique CD8 T cell population is actually expanded in this disease. So further analysis of this subpopulation, which is IgG CD38 and negative for CD127, have shown that these cells have a cytotoxic and a proliferative signature. So I would say that my comment on this is that this is a very nice example of lab work in terms of high-dimensional analysis such as CyTOF or single-cell RNA, but also the usage of CRISPR-Cas9 gene editing. I mean, everything done to aim for a better understanding of the roles of this cell population in the disease pathology.
Thanks, Eduardo. Are there any translational sessions that you'd like to highlight from tomorrow's program?
Thank you. I'm happy that you mentioned it. The new technology in translational rheumatology session will take place tomorrow between 11 and 12. And on another separate event, I will have the honor to have a short roundtable with two of our guests from this session, Prof. Leonie Tams from the King's College of London and Dr. Caroline Ospelt from the University Hospital of Zurich. So we will discuss together about the research and some of the new achievements in translational medicine. So please stay tuned.
Thanks very much. And do make sure that you catch that roundtable session with Eduardo on EULAR TV later. Now we'll go to Sebastian, who's going to be telling us some more from the rheumatoid arthritis sessions from today to continue what he was telling us yesterday. So over to you, Sebastian.
That is correct, Mridalini. And today I'm going to cover the biologic and non-biologic treatments in RA. And I would like to start highlighting a study that tries to answer the endless question of whether using methotrexate in RA patients poses a higher risk of developing ILD. To address that question, two Danish national registers were linked with the DANBIO register, and the association of methotrexate and lung disease outcomes were analyzed using adjusted Cox regression models. They also obtained standardized incidence ratios to compare the performance of these RA patients with the general population. And strikingly, they concluded that patients with RA have increased risk of ILD, as was expected, compared to the general population. But that risk was not further increased in patients treated with methotrexate compared to their counterparts. So these conclusions add to the body of literature providing more direct information about this very hot discussion nowadays regarding the development of ILD in RA patients treated with these synthetic DMARDs.
So it seems to be that it's more the feature of the disease and not the feature of the drug.
Yeah, that's something that was kind of implied from recent meta-analysis and other small studies. But I believe this is more definitive evidence because they had a very high sample size and they can analyze it pretty well and adjust for many confounders. So I believe this study will be very important because it's like it will close. I believe it will close this discussion, or it will provide very important evidence towards this very interesting research question. Secondly, I would like to comment on a very interesting study about the individualized prediction of methotrexate response through machine learning techniques, adding pharmacogenomic data. I guess we'll have to get used to see more and more of this kind of studies in the years to come in all areas around rheumatology. And briefly, they got two samples of early RA of around 300 patients, one of them from the UK and another similar sample from all across Europe. And they used supervised machine learning methods, adding data on age, sex, clinical, serological, and genomics data, comprising mostly genome-wide significant single nucleotide polymorphisms. And all these SNPs were associated with risk of RA and methotrexate metabolism mainly. The models were trained in the UK cohort, and then its predictive performance was analyzed in the remaining one. The outcome was the response of 15 or more milligrams per week of methotrexate in monotherapy, according to the EULAR response criteria. So the prediction models presented an area under the curve of 0.8, and the addition of this pharmacogenomic data improved the predictive accuracy of the models by 20%. So authors conclude that applying these predictive methods and adding this pharmacogenomic data will be very useful, mostly in predicting those patients who will not respond to methotrexate. So the treating clinician can opt to a timely escalation of the RA therapy. So we'll avoid losing our time, and we'll get earlier to the remission that's the target we're looking for in this patient. So I believe that we'll be listening. We'll be really listening with this kind of for this kind of studies in the years to come, like more frequently. And to finish, going back to the small molecules, I would like to comment on two studies. The first one is the one from the Jackpot collaboration that is being led by others from Geneva, and this collaboration gathers data from several European registers. In this study, they compare the effectiveness of JAK inhibitors to TNF inhibitors, abatacept, and IL-6 inhibitors. Rituximab was not included in this comparative study. And briefly, they found that the hazard ratio of discontinuation tended to be lower for JAK inhibitors compared to TNF inhibitors, but comparable to abatacept and IL-6 inhibitors. The effectiveness was analyzed in terms of retention. The retention rate of these drugs was the surrogate for its effectiveness. The others post that evaluating other measures of effectiveness, such as CDAI, that is something that has been done in the past for other studies like this. I think these other measures of effectiveness will definitely shed more light on these topics in the years to come. And on the other hand, and keeping on the comparison of the JAK inhibitor efficacy, I'll finish with an interesting Korean work presenting a Bayesian network meta-analysis of randomized clinical trials with the aim of investigating the relative efficacy and safety of TOFA, baricitinib, UPA, and filgotinib versus adalimumab, having adalimumab as the reference. In all cases, the JAK inhibitors were in combination with methotrexate, and the target population were methotrexate inadequate responders. So briefly, they found that the UPA-15 and BARI-4 groups showed significantly higher ACR50 and ACR70 response rates than the reference, and there were no difference in safety between the different intervention groups. Those were my highlights for today, and now we'll come back to Renali to talk about osteoporosis.
Thank you, Sebastian. Lots of varied talks you've been to today. So today, yes, I was lucky enough to be able to present at a couple of the osteoporosis sessions. So I'm going to highlight a couple of talks other than my own. So the first one was at the cost opportunity of screening osteoporosis in the general population. And I'd like to highlight the presentation on the incidence of fragility fractures in postmenopausal women with rheumatoid arthritis. So the aim of this study was to estimate the incidence of fragility fractures in postmenopausal women with rheumatoid arthritis, as well as looking for the risk factors of fragility fracture. So the researchers conducted a case control study with postmenopausal women taken from a large registry of rheumatoid arthritis patients across Spain, and the controls were age-matched postmenopausal women. And the study found that 3 to 4 of every 100 women with rheumatoid arthritis in the study cohort had a major fragility fracture per year, and that was 4 times more compared to the general population. So quite striking results. And in rheumatoid arthritis, disease activity and disability, the cumulative dose of steroids, which is quite important here, of course, and mainly previous fractures were associated with fragility fractures. So one thing which I would be quite interested to see as well would be what proportion of these women actually had hormone replacement therapy, for example, and did this have any impact on the fractures they subsequently sustained. But very interesting, would be quite interesting to see going forward in this cohort.
Really interesting. Do you also have some new findings about therapy and treatment in osteoporosis?
Yes, thanks, Fabian. So actually the second session, which I was at today, was on, well, it was called osteoporosis. And I'd actually like to highlight two abstracts, one from the oral session and one from the poster tour on denosumab, which is, of course, a very well-established treatment in osteoporosis. So the first abstract was in the oral session, which was a study from Barcelona on the risk of vertebral fractures after the withdrawal of denosumab. So this cohort consisted of 415 patients, 20% of whom had discontinued denosumab for various reasons, which were described in the presentation. And about 50% of those who'd stopped denosumab then went on to take something else, such as IV bisphosphonates, for example. And the duration of treatment that all of these patients had was about 2.75 years prior to the withdrawal of their treatment. So the group found that the incidence of any fracture in patients who discontinued their denosumab treatment was around 10.9%. And in particular, the incidence of vertebral fracture was around 8%. And the fractured patients actually had a lower bone mineral density gain with denosumab than the non-fractured patients.
That's quite interesting. Can I ask you a question? What happens when you delay the treatment rather than stopping it?
Absolutely. So this is actually quite a relevant question, given the times that we're living in. Sometimes, you know, given the healthcare system pressures at the moment, for various reasons, there may be delays in treatment, even though we try to prevent them. So I'd actually like to highlight an abstract from Professor Daniel Solomon's group in Harvard Medical School, who did look at what happens when denosumab treatment is delayed. And they found that delayed denosumab dosages over 16 weeks was associated with an increased risk of vertebral and major osteoporotic fractures compared to no delay, although the composite fracture risk was not increased with the longer delays. So actually, if you'd like to know more about that particular abstract, it was on the osteoporosis poster tour, and I interviewed Professor Solomon for EULAR TV, so make sure you catch that interview if you'd like to find out more about that. So yes, some interesting abstracts in this year's osteoporosis sessions. Now I'd like to actually pass to my colleagues Mikhail and Fabian, who are going to talk about spondyloarthritis. And first of all, I think we're going to Fabian.
Yeah, thank you. And I would like to start with some interesting insights about psoriatic arthritis, if I may. And there I had the opportunity to attend the oral presentation of Ian McInnes from the UK, and he presented the 52-week results of the EXCEED head-to-head trial of secukinumab versus adalimumab in the PSA patients. And even if the primary endpoint of superiority in achieving an ACR20 response at week 50 for secukinumab was not met, I think this study gives us great information for our clinical decisions in the future. First, concerning skin manifestations in PSA patients, IL-17A inhibition seems to have an advantage, also influencing composite indices. But when looking on the two available head-to-head trials, it can be assumed that the efficacy on musculoskeletal manifestations is at least similar for TNF inhibitors and IL-17A inhibitors. Which patient subgroups are benefiting from one mode of actions or the other will be a really important point for the research agenda in the future. And I also want to highlight one of the posters to PSA, and their data from the EuroSPA, which is a combined registry from the European registries, was presented. And they looked at the effect of concomitant conventional synthetic DMARD use on the retention of TNF inhibitors in PSA patients. And the presented data did not suggest that there is a beneficial effect on the TNF inhibitor retention with concomitant conventional DMARD use. And maybe I can go over to Mikhail, who had the chance to go to the treat to target session.
Well, thank you, Fabian. Indeed, I had the chance of checking the abstracts of the Treat to Target session in axSpA, which was called Treat to Target and axSpA Myth or Reality. A really interesting question. And the session was actually opened up with Annamoto giving the presentation, also with quite a provocative title, Treat to Target and axSpA, Does It Work? And she was presenting the results of the axSpA trial, showing that although usual care was also a very good treatment, and although the primary outcome, which is this point, was ASA's health index improvement, was not achieved, there was a general trend in favor of the treat to target strategy also in the axSpA in the majority of the other outcomes. And treat to target strategy was also cost effective at the threshold of 20,000 euro per QALY. So interesting results. And there were also two interesting oral presentations selected for this session. First one given by Augusto Ortolan, who has shown that ASDA's clinically important improvement and ASDA's major improvement showed a higher discrimination than the other outcomes for or other response criteria for differentiating between the treatment groups and placebo groups for axSpA trials. We all know that there are a huge variety of the outcomes available for the axSpA trials. So those two, ASDA's clinically important improvement and ASDA's major improvement, seems to differentiate between the responders and non-responders better, which will in future probably mean that the smaller sample sizes would be needed to achieve the same statistical power for the axSpA studies. And the second report was provided by Professor Rosenwiltran, who has reported the factors associated with the 5-year drug-free remission in patients with early onset axial spondyloarthritis. And she has presented the data from the Desir cohort. The study actually analyzed the proportion of the patients who achieved spontaneous drug-free remission 5 years after the diagnosis of axSpA and after being included in the Desir cohort, which is a cohort of early onset axSpA, including more than 700 patients at the baseline. So from the patients who were followed up throughout the 5 years, 17.2% of such patients were in a drug-free remission at the year 5. Not a very big share, but still almost 20%. And the patients who were able to achieve drug-free remission at the year 5 had initially shorter disease duration, lower disease activity, less arthritis, less enthesitis, less inflammation on the MRI and the baseline, so less severe disease, and also lower level of confidence of the physician in the diagnosis of axSpA at the baseline. So as said, they were generally milder and required less treatment as well. But interestingly, the acute presentation at the very beginning of the disease was also associated with the better prognosis.
Okay, Mikhail, thank you. Maybe I can take over again and also report on the findings that I have been had the chance to see on the actual SPA. And there was one analysis from the British Biological Registry, which were really interesting, I think. And here they compared the treatment response to biological DMARDs between the two subgroups of axial SPA, meaning AS or radiographic axial SpA and non-radiographic axial SpA. And the main message of this analysis is that there were no differences in the treatment response between these two groups, corroborating with the hypothesis of one disease with two subgroups. And they also had an interesting sub-analysis, and they showed that only about 20% of the patients treated with a biological DMARD showed a major improvement defined as an ASDAS decrease by more than 2 points after 1 year. So highlighting that only every 5th patient is reaching the target that we are aiming for. And I think this is giving us a strong indication that we need further treatment options and especially also complementary interventions on patients with axial SpA. And in patients where we don't have the efficacy that we are hoping for, we are probably switching the therapy. And there was one really interesting abstract from the colleague from Portugal, and Santiago Rodriguez Manica and his colleagues compared the treatment response of the second TNF inhibitor in regards of the reasons why the first TNF inhibitor was discontinued, because they had to switch. And in their registry data, they showed that patients with a secondary failure, so having first a clinical good response on the treatment of the TNF inhibitor and lost this efficacy over time, have a better response to the second TNF inhibitor compared to those discontinuing the first TNF inhibitor because of a primary treatment failure. So I think that the reason why the first one failed gives us an indication if we should continue with the mode of action, TNF inhibition, or maybe consider a change in the mode of action.
In such clinical cases, Fabian, I'm always asking myself whether we set up the diagnosis correctly. What would you say?
In cases of a primary treatment failure, I definitely agree that this is a time point where you really have to reassure that the diagnosis is correct. But on the other hand, we were just saying that only 20% of the patients with the clinical diagnosis by rheumatological experts are reaching the defined treatment target. So I think that definitely some patients are missed by the potentially available treatment options. So I do agree that primary treatment failure is the time point where you have to reassure yourself that the diagnosis was correct, but I think that it exists.
And those 20%, they obviously are much lower compared to the clinical trials. So what can be the reason for this discrepancy?
Patient selection, patient care in clinical trials, and yeah, also probably negative reports are not that often presented. So this might be the cases.
Very interesting, Fabian. Thank you for this really inspiring update. We really do need a better treatment, not for psoriatic arthritis and spondyloarthritis, but also for the other rheumatological diseases as well, obviously.
Absolutely.
But regarding the spondyloarthritis, I had also the chance of visiting the sections that were not related, or not at least directly related to treatment. I mean poster sessions that were named Spondyloarthritis, Clinical Aspects Other Than Treatment. And I would like also to present you a very short digest of the very interesting posters that were published there. So for example, Diego Benevento and co-authors just compared the demographic, clinical, and structural features between the patients with the axSpA and axial psoriatic arthritis, so psoriatic arthritis with the axial involvement, showing that axial SPA patients had less peripheral involvement, more uveitis, and were more frequently HLA-B27 positive in comparison to axial PSA patients, with other clinical characteristics being comparable. And also in the other poster, the same group showed that both of those groups had a similar clinical response to the biological therapy. Dr. Bigiotgero and co-authors also looked at the prevalence of extra-articular manifestations in spondyloarthritis patients who were treated with biologics, and found out that 13% of spondyloarthritis patients show at least one extra-articular manifestation, with a predictable trend towards anti-TNF treatment, of course, in such patients in comparison with other treatment modalities. And also to the topic, Atul Deodhar and his co-authors showed in another poster that despite strong efficacy in treating AS-related signs and symptoms, tumor necrosis factor inhibitor therapy does not really reduce the incidence of comorbidities and extra-articular manifestations in ankylosing spondylitis. Dr. Bilgin and a group from Turkey demonstrated that active smoking, high disease activity in males, bruxism in females, and neck disability to be predictors of temporomandibular joint involvement in patients with axial SPA, the joint involvement that really can be debilitating. Dr. Brown and co-authors were able to show with a systematic literature review that vitamin D deficiency is more prevalent in axial SPA compared to general population, but does not seem to associate with increased disease activity, interestingly. Dr. Wendling estimated the incidence rate of the uveitis in the desire cohort as 1.3 over 100 patient years, showing that uveitis was also associated with the other manifestations such as dactylitis, such as MRI inflammation in sacroiliac joints, and with the biological treatment. Dr. Karoubi and his team showed that HLA-B51 positive patients with axSpA might have a phenotype of the disease that is somewhat different from the typical HLA-B27 positive disease, and from patients who do not have neither of those HLA markers. So HLA-B27 is the classical gene known to be associated with the classical axSpA, and HLA-B51 is thought to be rather associated with Behçet disease, but it seems to be that it might also drive the phenotype in the axSpA somehow. Maria Lopp and co-authors looked at the radiographic progression in patients treated with the anti-TNF inhibitors to find out that radiographic progression is really observed, but the development and growth of the syndesmophytes seem to be lower in the long-term treated patients as compared to the patients who has just started the anti-TNF treatment, confirming the long-acting effect of the anti-TNF treatment on radiographic progression. Our team has also presented a couple of the reports, first on the gender differences in patients with axial spondyloarthritis, the data from the GASPIC cohort, regarding the radiographic progression, showing that there was a trend for male patients to have more radiographic damage at the baseline, and also somewhat more progression after 2 years of follow-up in comparison to females. And the presence of peripheral manifestations was also associated with distinct characteristics of SPA, including slower radiographic spinal progression. Fabian Proft looked at the rate of the disease flares in patients with early axial SPA receiving long-term treatment with etanercept. This was the long-term results of the ESTER study, showing that clinically important worsening occurred only in about of 1/3 of the patients without major difference between radiographic and non-radiographic axial SPA. Imke Redeker and co-authors has presented a very interesting report showing that women with axial spondyloarthritis have comparable rates of complications in pregnancy to women in the general population, but more cesarean deliveries compared to the standard population. And I would like to wrap up with a nice report and very actual report that was presented by Dr. Xishan Zhao, named social isolation is independently associated with more severe disease in axial spondyloarthritis. So certainly a point that should be taken in this times of the social isolation or self-isolation. So Dr. Zhao was able to show that living alone as a proxy for social isolation was associated with more severe disease and poorer quality of life in patients with axial SPA.
Thank you very much, Mikhail. And as he was saying, particularly with that last abstract, we're living in very difficult and uncertain times at the moment. And particularly with this e-Congress, we really hope you enjoyed it, even though we weren't able to be together this year. We hope that we will see you again next year, whether that is in person or again over a virtual platform. We hope you've enjoyed all of the content, and thank you to all of the presenters this year, whether you were presenting a poster or an oral presentation. To put this e-Congress together, it's been a lot of hard work behind the scenes. So we'd like to say a big thank you to the team at EULAR and all the production teams elsewhere who've helped to put this together to deliver so much content in such a short space of time. All that remains for me to say is, we look forward to seeing you in Paris next year for EULAR 2021. But in the meantime, it's goodbye from all of the EULAR News and EULAR TV team.
Goodbye.
Bye-bye.
Bye.